Professor Linda Smith, Chair of the Global Network of Public Health Nursing, and members of the Nursing Public Health Nursing Council present, Dr. Miriam Chair of the Local Organizing Committee for this conference, Ms. Annette Kennedy, President of the International Council of Nurses, and all our VIPs today who are the nurses and trainees to be nurses. I'm happy to be with you, and I bring you greetings from the champions for HIV/AIDS in Africa, champions of free AIDS generation in Africa. This champions of AIDS-free generation in Africa is chaired by the former president of Botswana, His Excellency Festus Mogae, who is fantastic as a health advocate. So the lady, and our vice chair is no less than His Excellency Kenneth Kaunda, first president of Zambia, who was one of the first people to declare that his own son had died from HIV/AIDS. And 12 other heads of states who are members of these champions to advocate for local ownership and financing of the HIV national response. And I happen to be the non-head of state member of that champions. So I bring you great greetings, and I'm happy to be here because I'm always happy to be in the company of nurses. In my professional life, I have been accused, or I have been given very many names. I have been given the name of a witch doctor because I was working in the communities with the traditional healers and everybody else. I've been called a community health nurse, I've been called a nurse, and I think the best one I like best is the nurse. Because my observation has been that you solve problems. And when doctors begin to threaten me about throwing me out of the medical profession, I always say I don't mind becoming a nurse if they can accept me, because you solve problems. And as I mentioned in my public speech, among my heroes in health have been nurses, like Muringo Koryene. I think you have all heard about the sad news that has happened to her family. Her spouse passed away on Monday. And also I told you about my classmate who became an outstanding nurse and died in a car accident on her way from duty at the age of 35. I thought I was going to die because she was very good and very cheerful. I wrote a book about her, A Nurse with a Song, which was published in 1978, and which I hope we shall be able to republish. So I'm very happy to be here, having recognized those old-time nurses. But I also am inspired by the young nurses. Young nurses like Linda Smith here, Professor Linda Smith from the US. Young nurses like Professor Dr. Rosemond from UK, from Karen Whitaker, from Harriet. And I'm also inspired by young Kenyan nurses like Teresa Obwayo, who has been inspiring me and keeping in touch with me to see how I was preparing. Elizabeth Ojuer, Lucy Kiputi, and Professor Anne Karani, all of them very active, very productive, and getting things done. So I'm very happy to be here. And I'm very happy also, if I may say in advance, about the conference in 2020 on From Healthcare to Health. Only nurses could think of a title like that. Because many of us are just focused on disease. And I always tell my colleagues in the medical profession that it is the World Health Organization. It is not the World Medical Organization. I think the people who decided that were very, very wise to make it the World Health Organization. And this is why I have been advocating that instead of having DMS, the Director of Medical Services in our ministries, we should have a Directorate of Health Services that is co-led by a nurse and a medical doctor, because you must have the two. So long as one is at the top and one is at the bottom, it doesn't always work, because you always have to get the permission of the one at the top. But we need co-ownership. Directorate of Health Services has been one of my recommendations. So I'm very happy to be here and to talk a little bit about the training, development of public health professionals in Kenya. To begin with, WHO has told us a universal truth, that without health workforce, you cannot have health. No health without a workforce. And they have given us the minimum threshold of health workers per population, per 10,000 population. Unfortunately, many countries have not reached the ratio that the WHO gave us in 2013. Only 44.6% have reached that ratio. And of the ones that have not reached it, 70% are from sub-Saharan Africa. So you are in the right place for this conference, because we need solutions. And you are going to be the ones to help us, because you provide solutions. According to the data of 2007, which has not changed, 11% of the population of the world is in sub-Saharan Africa. But 24% of the disease burden is in sub-Saharan Africa, with the 3% of the workforce and 1% of the health expenditure. So you can see that we are in a tight spot, and we must have innovative solutions to bringing about health. Otherwise, we shall always be under the disease burden and be preoccupied by disease. And I always tell my colleagues in medicine that we must be preoccupied with health, not with the disease. And it's a very difficult sell, because we like to deal with diseases. But there's some good news from Africa. And the good news from Africa is that, small although it is, we are the leading in exponential growth in the growth in members of the health workforce and density in skilled health workers. So we do have a leadership in that area. But to maintain that leadership, there is a lot of advocacy required from us and from everybody else. And this includes having long-term sustainable plans, long-term political commitment. And this is why I say that that's why I said in my public speech that some of us in the health sector must become politicians. We older ones must encourage young health professionals, nurture them to actually be active political people, to join politics, not to work from the health sector, but to work from the political platforms. Because this long-term political commitment, again, talking from the outside, hasn't worked very well for us. We need people inside the politics who are health professionals, and not to accuse them of betraying the health professional by going into politics. We need established databases, and we need adequate investment. We need advocacy for all this. It is a very long order, but we are trying to do something about it in Kenya. To do any of these 4 items that I think we need to do, you need information. And so I'm going to talk mostly about information. What information we are generating in Kenya to help us make decisions to move forward. But first of all, I would like to say that what we have done is to have a definitive structure of the health system. And the strategic plan for 2012-2017 was clear in guiding us on where we should be going. And they named it in tiers, 4 tiers. The first tier is community health services. It did not appear in any of the official health documents until this time. This is the level that focuses on health promotion, disease prevention, and first-line curative services. Tier 2 is the dispensary and health center. These are the levels that provide backup to the community health services. Tier 3 are the county hospitals. In Kenya, our country has been decentralized into counties, 47 counties. So every county has a county referral hospital. And level 4 encompasses the national referral hospitals, which in the old days used to be called level 5 and 6. Since we are really at this time, in this age, and at this conference, I believe, preoccupied with universal health coverage, our main focus is level tier 1 services and tier 2 services. Only a small proportion should be going to tier 3. And very, very small proportion should be going to tier 4. Unfortunately, right now, our tier 4 and tier 3 are congested. Long lines, many people. And you'll find some on the floor of the beds because we are not effective on tier 1 and tier 2. And we seem to think that the more expensive medicines the more expensive equipment we have, the more white elephant hospitals we have, the more we think we are providing health. We are not providing health. And the fact that even our immunization rate has been going down, has been dropping, is a very good pointer that we are not moving forward. So we need the first essential need to make a big difference is the health workforce. So how do you get information from the health workforce? I want to express our thanks in Kenya to the government of the United States of America through USAID and other agencies in that country for having helped Kenya to begin to establish a database using the various regulatory bodies. And I'm glad to say that the Kenyan lady that has been heading this work is no other than the former Chief Nursing Officer, one of your colleagues, Agnes Waudo. She has been heading this work, and we have got we are beginning to have a very good base of information. And the first organization that took up this challenge was, of course, the Nursing Council of Kenya, as you might expect, and established a very good database. And from that database, other professionals began to realize that, oh, we could also have a database. Among them were the medical practitioners and dentist board. And so I have listed here the various regulatory bodies in Kenya which determine the programs to train, the criteria for entry, and so on, and which have been the source of information on health workers in Kenya. I had set out to find out information towards providing public health professionals, but it was difficult to tease out the public health professionals from the information available. Secondly, you just work where you are assigned, whether you are a public health professional or not, you just work where you are assigned. So you do the work that you are required to do. You may not do it very well, but you do it anyway. So the beginning point is to find out who is in each of these specialties. Why do I say that health workers, the health workers that are really critical are the ones for level 1 and 2? All health workers are critical, but I think that the level of critical level is 1 and 2 are the ones who are critical for reducing the disease burden. In my 50 years or so of experience, the disease burden is always, to me, like an epidemic. Until you get hold of an epidemic and start to put it down, you really can't function very well. Tiers 1 and 2 are very critical if they are properly staffed and effectively serviced. When you focus on level 1 and 2, people accuse me many times of ignoring level 3 and 4, as if I'm undermining level 3 and 4. They accuse those of us who make it a case that we must strengthen level 1 and 2. But we find that the more effective level 1 and 2, if you go to areas in this country where level 1 and 2 are working effectively, you find that there is decongestion at level 3 and 4. And therefore, it gives patients a chance to be seen properly. Because when I was practicing in a clinic, I used to spend 2 minutes with a patient because of the 200 waiting out there. And it is 2 o'clock and the work is going to end at 5. What is your problem? Coughing, cough mixture. What is your problem? Malaria. So it's not health care. That's one of the reasons I stopped working in the clinics. So by focusing on level 1 and 2, we are not undermining level 3 and 4. We are saying that they can be more effective. And also, it is in the interest of the health workers. There is less burnout when you are not dealing with 500 people looking at you to provide answers for them. So focusing on effective level 1 and 2 is very important for everybody, for the patient and for the health worker. And I think that nurses are very critical because they are the people whose professional workers are at level 1 and 2. And rather than look at this as, oh, this is what I was saying the other day, that sometimes we make a mistake ourselves as health professionals. We want to give more glory to the ones who are working at the referral level and sort of dismiss those working at the first and second level. We must give them dignity, we must give them respect, because they are the foundation of a healthy nation. So, some of this may not be very clear, and I will go very quickly through them, because if you would like to see them, you can see them from the paper. We are a very low population, health worker population ratio. For medical doctors, it is only 1.5 for 10,000. Fortunately, for nurses and midwives, it is at least 8.3. And so we still have a challenge of the ratio of the health worker to the population. When you go from this general picture to go to the nursing programs, the next stage is the nursing programs. I like this table the best because it gives us the various levels of nursing that are under the regulation of the nursing profession. You have the Kenya enrolled nurse, you have the Kenya, these are the certificate level. You have the Kenya enrolled midwife, you have the Kenya psychiatric nurse, and so on, enrolled community health nurse, Kenya enrolled community health nurse, midwife, Kenya, then you come to the Kenya registered nurse, Kenya registered nurse, registered community health nurse, Kenya registered nurse midwife, Kenya registered neonatal health and psychiatric nurse, and so on. So this whole level, this whole table is made of different categories of nurses. So the point I want to make with this table is that we have nurses who can cover every area of our work, every level and every area. And this is what gives the nursing profession in this country a lot of power. And I would like to see that power expressed more. The others are just pass over it. The clinical officers are the ones who are the equivalent of the physician assistant in other countries, like in the US, where they do diagnostic work and they treat. The next level, let's just move on, are the pharmacists and pharmaceutical technologists, who are very important in healthcare because they are the ones who organize how we get our medicines. And then we have the approved medical laboratory training programs. Again, these are very important because they help us to diagnose in definitive terms who is sick from what so that we can treat them. So even at level 1, we need to have a laboratory technologist or a laboratory technician to help us treat them. So what I'm trying to say is that in order to have a health workforce, we need a database. And in Kenya, we have started on establishing effective databases, thankfully with the help from our colleagues from the US who have helped to sponsor this work, in addition to Kenyan involvement in it. So if we have an effective database, you'll find from these tables, if you are interested, when you look at them, that there are entry levels, there are requirements, and there are also regulatory processes for each of them. So we must have this, because when we are talking about universal health coverage, we are not talking about shoddy health care. We are talking about good, effective, professional health care, but provided at the appropriate levels. We are saying that you don't need a gun to hit a fly. It is not wise. Just because you're using a gun to hit a fly doesn't make you wise. It makes you actually look foolish. We must have appropriate equipment, appropriate people at each level. And I think that with this information on the database, we are beginning to have a good understanding of how to get to appropriate health workers for appropriate levels. So if I may just talk a little bit about the nursing profession, there are very clear minimum entry criteria for diploma nursing. The pre-service, the one that you get before you go to school, is there. There are entry levels for those who are already nurses in the service, like enrolled nurses, who need to upgrade themselves to the diploma level, the in-service training. There is also minimum entry for degree level. It took a long time for this country to establish degree level nursing, but thank God we did establish it in the medical school of the University of Nairobi, and it is now available in all the universities who have got a medical training. I have been the chancellor of Moi University, and Moi University has one of the most vibrant degrees in Bachelor of Nursing. So it is now recognized that nursing must be at the university level. And of course, when you get your first degree, the Bachelor of Nursing, you don't end there. You can go to master's, you can go to PhD, and we have many who have now done that. And it is one of the wonderful things I have seen in my own life, that we have removed the ceiling. This ceiling used to be there, that degree work is not for nurses. And we fought about it. We fought it in faculty boards and got it established. And so now we have the possibility of having nurses at all levels of the system. And I think this is one of the strengths of the nursing profession, that you have people from all levels who are under the same regulatory body and who can therefore influence the entire health system. We shall pass over the other regulations quickly because they are there, but if you're interested in them, you will read them. They include pharmacists, they include medical doctors and dentists, They include laboratory technicians, they include public health officers. Public health officers are what used to be called environmental health officers. They were very important for helping us to keep our environment clean, and also very important for inspecting food that is being sold on the market. For instance, inspecting animals to know are the animals healthy before the meat is sold. Like anthrax, is the animal free from anthrax? Is the animal free from other diseases? And generally inspecting our public eating places so that they are clean. They are very important for public health. And the fact that I'm not dwelling on them does not mean that they are not important. And then we have nutritionists. Nutritionists who, again, are very important because we are all becoming very much aware that nutrition is key to health. It's not a by the way. And one of the things that has happened in Africa, and maybe in many other developing countries, is that we have been very excited about the new ways of eating that we see in our hotels. The fish and chips and this, and this is coming into the home and influencing our health. So it is important to have nutritionists who can guide us on proper diets. Radiographers are also very important. As you know, if you have a problem that needs radiography or radiological service, it is very important to have those professionals. And now we have information on them in Kenya so that we know. And now that we have got a decentralized system, we can actually say how many are in each county and how many do we need. So it is no longer lack of information. It is actually how to put the information that we have to work for our health. And if I may come to what I consider the most important part of this presentation, the special place of nursing profession in Kenya, I just want to repeat again that nurses are the largest health workforce in this country, providing 45% of the health workforce. And I think equally important, covering a whole range of professional levels that help us to cover the entire populational system. Nursing professionals provide, it is said, estimated 84% of health services. The nursing profession has a wide range of professional training programs. And as I have already said, this means that you can be at all levels of the system. You can influence the whole level system. And I think that is one of the big strengths that nurses should use to express their power and influence on the health system. And this is why I think we should stop having Directorate of Medical Services and instead have Directorate of Health Services, jointly headed by a nurse and a medical doctor, so that there is influence at the top. I was telling someone the other day that it should not just be a question of the nursing services are there and the medical services are there. It should be the Director of Health Services should have one entrance. It should be built in such a way that it has one entrance, one door going to the nursing and another door going to the doctors, so that it is clear it's co-ownership, it's co-leadership. And I think that this will help us to give to the nursing profession the power and the place at the table that it requires. I was very happy to hear about carrying your chair to the table that someone was mentioning yesterday. It is very important. But if there is no table for you to carry the chair on, you can stand with the chair and it will be heavy on you. So we need to have a place for the table, and then have the table, then you can carry your chair to the table. Huh? There must be facilitation of that. And I think that nurses can do that very well. The next tables give very detailed information on the nursing by county, and I will not go over it. If you're interested in it, you can find it in the table. So finally, I just want to say again, I am accused quite often of repeating things, but I have found that in my teaching role, that seems to be the only way that people remember. Nurses are key for achieving universal health coverage. In Kenya and in Africa, we have an epidemic. That epidemic is called disease burden, heavy disease burden. I look at it as an epidemic. And when I used to be a young doctor managing epidemics, you must put an end to the epidemic in order to move on. You cannot move on with the epidemic still raging. We have been having this epidemic of the heavy disease burden in Africa raging. We used to have only communicable diseases. Now it has been joined by the non-communicable diseases. We must get hold of it. HIV/AIDS constitutes one of the biggest proportions of this disease. HIV/AIDS is a preventable disease. And it is a preventable disease mostly through behavior. And we cannot manage it from the hospitals and from the clinic. We can treat it there, but we cannot stop it from there. So this is why, again, I say it must be at level 1 and 2 to help people understand how it is spread and how we can provide, how we can prevent it. So this disease burden, we must treat it as an epidemic. And we can only treat it as an epidemic by paying priority attention to tier 1, community health services, and to promote health, to prevent disease, and to give first-line curative services. Even now I get shocked when I go to a health center or a hospital and find diarrhea there. There should be no diarrhea being treated at the hospital. It should have been done elsewhere, long time ago. And that's what we need to do. And then we need priority 2, which is the health center that provides backup and referral to the health system. So we need to develop health professionals that can do this. And finally, so how can the nurses deliver UHC in Kenya? I think nurses should help us to ensure that community health workers are within the workforce. Right now, they are not within the workforce, and they are not remunerated. And there is an idea that they should be volunteers. How can you volunteer when you have nothing to eat? You volunteer every day, all week. How can you volunteer when you have nothing to feed your children? Even in the villages where I was doing the pilot work in the 70s, they told me, no, these community health workers, we must pay them. The village used to contribute money to pay them. And here formally, we say, no, they are volunteers. And they come to me and they tell me, you know, Mama, we have to sell our bodies to feed our children. How do you think we feed our children? You people, you have forgotten us. How do you think one of them was with me in Kigali and she was telling me, how do you think I can buy a dress like this on a volunteer work? How? So they do that and are forced into other illegal things I don't need to discuss here. We must get community health workers within the formal health workforce and on remuneration structure. I have been told before that there are too many, but we have also known that for every dollar that is invested in a community health worker, the benefits are $10. So it is the most effective system. We need to develop a curriculum for the community health workers. We need to advocate, and I think the nurses can help do this well. We need to advocate for the establishment of effective dispensaries in every ward so that they can provide backup and supervision to the community health services. And so, the nursing profession in Kenya, you are key to us achieving universal health coverage. Become the prime movers, and we shall support you. The rest of us will support it. Let us have a country approach to UHC so that it is happening simultaneously and we can achieve it in every county. And in conclusion, I am very happy that the Global Network for Public Health Nursing has come to our country and to Africa. We rejoice in seeing you here. We rejoice in your expertise and your interest. And we thank you for helping not only Africa, but the world to become healthier through achieving universal health coverage. So I thank you very much for being here, and I thank you for taking the leadership to move from disease to health, because disease is not our priority concern. Our priority concern is healthy lives and health-promoting environments at all ages and at all stages. Thank you very much.